My name is Daan Bosshardt. I work in the Amsterdam University Medical Center in the Netherlands. And today we'd like to talk to you about a recent publication into JMRI named Aortic Function in a Longitudinal 4D Flow MRI study in Marfan syndrome patients receiving Resveratrol. Marfan syndrome is an inheritable connective tissue disorder, and its most major manifestation is an aortic aneurysm formation, which occurs mainly in the aortic root. And if left untreated, this can lead to aortic dissection. The causal mutation is within the fibrillin 1 gene, and the mutation within this gene can lead to elastic fiber disorganization and elastic fiber fragmentation, which ultimately leads to dilatation and dissection. Resveratrol is a dietary supplement which has been shown to decrease extracellular matrix degradation, decrease endothelial dysfunction, and decrease smooth muscle cell death. In mice, it has been shown to decrease aortic growth rate, and more recently, we did a study in humans, Marfan patients, where we saw a trend towards a decreased aortic growth rate in the aortic root. However, we do not yet know what the effects on the aortic hemodynamics are of resveratrol. So in this study, Marfan syndrome patients with a pathogenic fibrillin 1 variant were included. Patients with an aortic diameter beyond 50 millimeters or had other reasons for surgery to be probable within the next 6 months were ineligible. Also, patients with recent history of aortic root surgery, aortic dissection, or with current or planned pregnancy were ineligible for participation. At inclusion, patients would undergo a study MRI where aortic diameters and aortic function would be evaluated. Then the patients were followed for 1 year where they were treated with 500 milligrams of resveratrol treatment on a daily basis. And at the end of the study, all study examinations were repeated. So to evaluate aortic hemodynamics, we used 3D phase contrast MRI or 4D flow MRI. And we acquired this on a 3 Tesla system. We used a pseudospiral acquisition pattern with compress sensing reconstruction. And we evaluated velocity and wall shear stress throughout the thoracic aorta. We evaluated these parameters at peak systole and calculated the regional averages within each region of interest, being the 2 in the ascending, 2 in the arch, and 2 in the descending thoracic aorta. To get some further insights in location and magnitude of abnormal flow, we acquired such called heat maps and incidence maps of abnormal flow. So we acquired data from 25 healthy age and sex match controls. And by registering these together, we were able to identify on a voxel-wise basis the 95 confidence interval of normal values for that location in the aorta. And in the same way, we were able to assess the normal vector of that place in the aorta. And we could then compare that with the patient's aorta and thereby identify regions with abnormally elevated flow or abnormally directed flow. So in this example, we looked at the abnormally directed flow, and you can see some abnormal flow in the ascending and proximal descending aorta. If we then group all the patient data together, we can create such called incidence maps, which depict regions where within our cohort abnormal flow is commonly present, as you can see in here, as depicted by the percentage. So we were also interested in the pulse wave velocity, as it's an indirect measure for arterial stiffness, and it's known to be increased in patients with Marfan syndrome. So to do this, we need a higher temporal resolution. So we reconstructed all the data to the 20 milliseconds. Next, we plotted all the flow waveforms across the thoracic aorta. And if we then calculate the delay times using a wavelet cross spectrum method and fit a line through the wavelet delay distance plot, we were able to calculate the pulse wave velocity. So onto the results then. We included 60 patients initially for the study. Unfortunately, we had to include 3 patients due to poor image quality and 1 quit the study. And in 11 patients, we were unable to make the 40 flow MRI, and this was mainly due to time constraints in our scanning slots. So we were left with 46 patients. 26 of them had a native aortic root, and 20 patients had a history of aortic root surgery. And if we then look into differences between those 2 groups, we could see that there were more males in the operated Marfan syndrome group, and the body surface area was also larger for the operated Marfan syndrome patients. So if we then look into the hemodynamics result, we first look at the velocity here in the 6 regions from the inner ascending aorta to the outer descending aorta, with on the left side the native, on the right side the operated Marfan syndrome patients. And as you can see here, at all the regions there was no significant differences between baseline and follow-up. Likewise, we looked at the regional wall shear stress, and also here we found really similar values at baseline and follow-up. So if we then look into the incidence maps, which depict the regions with abnormally elevated or directed velocity and wall shear stress, we first look at the native Marfan syndrome patients, and there we can see that wall shear stress direction is really abnormal in the ascending aorta. And if we then look at the operated Marfan syndrome patients, we can see that the velocity magnitude is really elevated in the ascending aorta. And also interestingly, we see this region in the proximal descending aorta where wall shear stress is abnormal, both for native, but in particularly in operated Marfan syndrome patients. And lastly, we see that none of these abnormal flow patterns seem to change from baseline to follow-up. Then we also look at the pulse wave velocity, as you can see in here, for the native and the operated Marfan syndrome patients reported separately. And we can see that there was no statistically significant change in pulse wave velocity values. However, maybe there's a trend towards a decrease of pulse wave velocity, at least visually, for the operated Marfan syndrome patients. So we also performed some correlation analysis, and there we found that for the operated Marfan syndrome patients, age was negatively associated with wall shear stress in the outer arch and outer descending aorta, and it was negatively associated with velocity in the outer descending aorta. And lastly, also for the operated patients, we found a positive correlation between pulse wave velocity and age. So in this study, we were unable to demonstrate an effect of resveratrol on aortic hemodynamics. This could mean that there actually is no effect, but it could also mean that we're just not able to measure it with our current techniques. Secondly, we found abnormal flow in the inner proximal descending aorta, which was most pronounced in the operated Marfan syndrome patients. And this is of interest as type B aortic dissection is known to occur in this region in these operated Marfan syndrome patients. So for that reason, this deserves some further investigation. Certain limitations apply to current study. So first of all, our follow-up duration was rather short, being 1 year. Of course, a sample size of 46. Well, it's not small, it's also not large, so a bigger sample size would of course be better. Then for the creation of the atlases of healthy volunteers, a different acceleration method was used compared to the patient population. However, we have previously shown that results from these both methods are very similar. And lastly, it would have been interesting to also assess cardiac function, but this data was unavailable for the current study. So to conclude, we found no changes in aortic hemodynamics and arterial stiffness derived from 40 flow MRI after 1 year of resveratrol treatment in Marfan syndrome patients. Thank you.